Good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dull Simons Family Studio. Delighted to be back with you on this beautiful Monday morning. There may be a little rain and sleet and snow coming, but we got truth coming today, Hawkeye, and we're happy to be back. Welcome back for Christmas. Our guest today is Patrick Sallee, the CEO of Vibrant Health. Patrick's a good friend of mine. He's done a great job helping build Vibrant Health. We hope everyone tuning in today also had a wonderful holiday weekend, but we know that's not the case for everybody, including some of the good folks at Vibrant Health who worked very hard to help our community out. Patrick's going to address that, but before we get all to that, the numbers really dropped over the weekend, Hawkeye. How are they today?
Yeah, looking at the numbers around the nation and the numbers in our region, I think we have some room to be optimistic.
Yeah.
Because the numbers are dropping.
It was a Merry Christmas present, huh?
Yeah. Now, again, goes back to the weekends with there may be some delayed reporting or decreased testing, but overall it looks better. Specifically, what we're dealing with today at the health system, I think we need to be really happy compared to what we were. So 56 acute infections in the hospital.
Really much better than 80.
Yeah. Or the 100, 102, 104. 24 in the ICU, which is, a fairly good portion, and 18 on the ventilator.
Also down.
We do have 61 in that post 10-day period after their infection, so that recovery period that we talk about, with 7 still on the ventilator, but 117 total patients, so that's a lot better than where it has been.
Yeah, we got up in the 160s there, and that was kind of high, maybe even a little bit higher than that, so that's definitely better. What do you attribute that to?
Hopefully it is people getting the messaging out, people doing the right things. We know that certainly there was a lot of activity before the holiday season with shopping and maybe going out, wearing the mask, not meeting in even those private homes, not meeting in those groups as they hopefully would have done in years past. Doing all those things, all those little pieces, I think add up to a total or a sum that hopefully is helping decrease the amount of new cases and, of course, decrease hospitalizations here. Hays is still pretty high, though, 27 total patients with 21 active and 6 in that recovery period. So that's still a good proportion of their patients as well.
I think you have to look back and say a lot of this has just got to be due to the mask mandates and things like that in the metro area, and people just doing the right thing and following the pillars of infection control because they really do work.
Yeah, absolutely.
Yeah, so maybe there's some truth to all those things we've been saying the last few months. All right, before we jump into questions, let's see if there are any reporter questions today. I'm not hearing any. I think everybody's happy after Christmas. I also want to know, you made another good point. The numbers in the Kansas City metro were in the 500s and 600s per day. Now, you're right. There may not have been as much testing being done, but our hospitalizations look like that curve, right?
Yeah.
We could say, it's a not, but the reality is hospitalizations are an independent variable from how many people you test, because the number of people you test doesn't impact. It's the number of people who are positive and getting sicker. Our hospitalization numbers are down. The city's numbers are down. It'll be interesting to see what happens post-holidays and whether or not people really completely follow the rules of infection control. But, I was pretty impressed. The Christmas crowds, I was out shopping a little on Christmas Eve day, and I will just say there weren't quite as many people as I've seen before. And the restaurants are not as busy on the inside. The groups I've heard about are smaller. Churches aren't gathering. There are just a lot of things that say to me, this is real. People are starting to get that message. They're doing the right thing. They're bending the curve. Patrick, how do you feel about that? How are things going in Vibrant? How is your team? Are they staying healthy? What's your sense about Wyandotte County?
Well, happy holidays, and thanks for having me again. Things are going well at Vibrant Health. One of the things I think is interesting that we've seen, or I guess haven't seen as much, that shows some of the trend here is we're not seeing some of the same sick visits that we normally would. So even just the standard sort of flu and cold and illness of this time of year, we're not seeing the same numbers that we normally do, which I think is attributable to schools being virtual in a number of districts and people following the guidelines as you just described. So going into the holiday, our testing was down a little bit. We just we'll probably talk about vaccine, but we're just gearing up for being able to distribute vaccine. So it's an exciting time.
So you've gotten some vaccine. Talk to us about which one you've gotten. How have folks done with it? Have you been able to vaccinate your team?
We have. So we got we got a shipment of the Moderna vaccine on Tuesday of last week, and we were able to vaccinate all of our staff that were interested on that day. And we have started vaccinating some additional healthcare workers in Wyandotte County late last week, and then we'll have a big push on that this week. We're working closely with the Unified Government Public Health Department, who has a big vaccination site at the old K-Mart at, I think it's 78th and State Avenue, where they're starting with health workers, but the projection right now is mid-month, mid-January, I guess, will be to sort of phase B of this, and being able to start with patients that are over 75 in some of those high-risk areas. But about half of our staff were interested in the vaccine and have taken it. I think we have a lot of the people that were on the fence and said they want to sort of wait and see. But we had a couple of people with small side effects, but nothing significant.
Okay, so half. So what about the other half? Why are they saying that they don't want to have the vaccine yet?
It's a combination of things. So we've asked everybody on staff to consider it and to inform us as to why if they chose not to. And some of it is they had COVID earlier in the year and felt like it was unnecessary. Some of them just generally concerned about vaccines and want to wait and see what happens. So it's a combination of things. I think a lack of understanding of what is in the vaccine and concerns about how it's going to work. So there's just a lot of misinformation out there that I think finds its way even to healthcare workers.
We're running about 65% of people offered getting the vaccine. There's this one rumor out there that a bunch of people, are even up to 1 in 4, are getting Bell's palsy. Hawkeye, have we seen Bell's palsy? I don't think we've had it.
No, I don't believe we have.
We've had a little bit of flushing. We've had a little bit of kind of a metallic taste in the mouth, and maybe one person who had a semi-allergic reaction, but nothing really significant at all. And I would say, compared to a lot of other vaccines, it's been kind of boring, which is good. So I'm a fan, and we have to remind our audience that this type of vaccine is not brand new. We have vaccinated people using the mRNA technology before, Hawk.
Yeah, absolutely. Again, 1 in 4 with Bell's palsy. I think there were 4 total in the Pfizer trial, and that's 30,000 people. So 1 in 4 is extremely high. And again, it's not new technology. They've been looking at using it for different vaccines. The platform has been there. This is the first time we've been able to ramp it up quickly because of the need around the world to do that. But really, I think it's proven and shown to be safe so far. And we'll continue to evaluate, obviously.
Patrick, so for your team, first of all, you shared some vaccine with us because you got enough that, and we really haven't had that. We've gotten a lot, but not, we have a team of 14,000. So just wanted to say thank you for that great effort. You might talk to our audience a little bit about what an FQHC, Federally Qualified Health Center, is, and the folks at Vibrant serve so faithfully. Talk to us a little bit about your mission.
Sure, thanks. And happy to share. The express message from the state when we received vaccine was make sure you get healthcare workers vaccinated. So we're trying to do our part. So as a federally qualified health center, we operate under federal guidelines on sort of our governance model, as well as how we interact with patients and the services we provide. So it's medical, dental, behavioral health care, adults and children. We operate out of 3 locations currently in Wyandotte County. We take commercial insurance, we take Medicaid, Medicare, and also have a sliding fee for uninsured patients. So about half of our patients, 45% of our patients, are uninsured, so they pay a sliding fee scale based on income. So our federal grant dollars and our commercial and Medicaid and Medicare reimbursement and philanthropic dollars help make it so we can take care of patients without insurance. So a lot of our patients, we served about 10,000 patients in 2019, a little bit down from that this year, just primarily due to COVID, but steady 10,000 patients, and lots dealing with diabetes, hypertension, chronic disease management. So there will be a significant push from us once we are able to open it to patients to try to get the vaccine out.
You know, it's an interesting point you made that you're not seeing a lot of other illnesses, and honestly, neither are we. You know, our actual hospitalization numbers from folks who are here normally are pretty low relative to what they should be for this time of the year. And I think there's pretty good data out there saying that folks, it's not that people aren't getting sick, they're just not getting care, Hawk.
Yeah, that's true, and we've known that has happened since this started, and whether it's the routine care and the routine exams that were needed, or it's even emergent care with, you know, maybe it's heart attacks that are light at the time, and you're not seeking medical care on your own, those things of that nature. But we've also seen certainly influenza around the nation is low as well, so people aren't seeking care for those, just as Patrick had talked about. We need everybody to continue to get their care, get those routine vaccinations, get those routine exams, those screening exams, all that stuff. And certainly if you have acute issues that you identify and are at home and need to seek medical care, continue to seek medical care, because the safest places in the region right now are the hospitals, because of all the systems and protocols that are taken in place to keep employees and patients safe.
All right. Well, Jill, let's see if there are questions out there from the community that we could try to answer.
Okay, Cindy has one. She wants to know for Patrick, if you're having a little bit of trouble with healthcare workers getting the vaccine, how are you going to get people in the DOT, patients, to take it?
So,
how will you educate them?
How do we educate the DOT, and are you doing it bilingually?
We are, or we plan to. So we haven't made our big public push yet on information, but it's a great question. So part of it is leading by example. So internally, we've had one of our longtime pediatricians was the first one to take the vaccine, and so we're going to do the same with community leaders taking the vaccine and sharing their experience, so that you're meeting people with messaging around people they trust and people that they know. And we also we work closely with the Public Health Department and the Health Equity Task Force, which has a lot of community leaders that aren't healthcare related participating in it, and those leaders will speak to their congregation or their organizations or people they work with around their experience. And so our hope is that very much word of mouth trust and confidence will build around interest in the vaccine.
Yeah, it's not a one-day thing. This is a long-term commitment that we have to make to getting people vaccinated. And I think, Hawkeye, we're taking the same strategy. Although I will say most of my patients are anxious to get it. They're asking a lot about it. But I think that's because we've got a chronic disease population that may be a little different.
Yeah, absolutely. And we talked to Chris Brown last week, and he talked about vaccine hesitancy, especially in the minority groups that have historically had other issues with healthcare and maybe not so honest means of going about doing testing and experimenting and all that. We will continue to answer the questions as needed, to continue to get the message out there, really go with what is in the news and the FDA and the CDC as far as safety, because that is important. And the hesitancy is okay, but again, continue to understand and seek those true answers and that true knowledge so that you can come to a true decision on whether you actually do not want to get it or want to get it. We also have to understand that there is that signal from Moderna that, as Patrick had mentioned, some people had it in the past, maybe earlier, and didn't think it was too bad for them. But certainly there is that early signal there that getting in that Moderna data that if you get the vaccine, you can also help reduce the risk of the spread of the disease as well, even if you don't get ill. And so that is another thing to consider so that you can protect other people in case you do come into contact with the virus again.
Hawkeye, one thing we haven't commented on yet is this variant strain that has now been found in multiple countries, including Canada. So we know it's in the United States as well. So talk to us a little bit. What are you reading? What are you hearing about it mostly?
Yeah. So again, I just looked again this weekend and this morning again with the weekend news cycle and the holiday, probably not much more, but other than it looks that it may be more transmissible. It does not look to have an effect on disease severity. And right now, it does not look like any of the vaccines are rendered useless with this new variant. I think even AstraZeneca maybe came out and said that theirs will work with it. So I think right now, as far as the vaccine goes and the new variant, there doesn't look to be any changes there. Of course, we'll be keeping up with any new information.
Yeah, and I'm with you. The weekend news cycle is a little quieter around a holiday weekend, which is great. But also, everything I read says it's been, it looks like it's more transmissible. Talk to us, why do you think it will be more transmissible?
You know, I think the best thing we have right now, and again, this is not just one mutation. There was an amino acid substitution at one of the amino acid sites on the spike virus itself. And it may be that it keeps it in that open conformation more at a higher rate, which means when it's open, that means it is able to actually bind to the receptor on our body. So if it's more open, more of the time, we know that with that one variant that we have seen, the D614G, one of those that came out in the spring, that it seemed to be more on the open conformation where it can readily bind to the receptor. And that might be one of the reasons that it can, is its ability to bind to our receptors in our respiratory tract to make infection easier as far as that goes. That is the best estimate that we have, or best thought as to why it's more transmissible. But again, this particular amino acid substitution is also correlated and also associated with, I think, 12 or 17 other mutations within this variant as well, and a couple in particular. And we knew that with the other variant that we had seen, the D614G, that had kind of cropped up and became more predominant. There was also an association with other mutations there. So it's nothing too new. You know, what would have happened back 50 years ago when new viruses came up, or when polio came out and was discovered? Would there have been a predominant strain? We know there was a predominant strain that occurred with SARS-CoV-1, and we just understand we have more technology to readily seek those and identify those than we did in the past, where more was just clinical, are you sick or not? And now we're actually able to more easily take all these isolates and look at their genomes.
Yeah, big deal. All right.
Simone, on a follow-up question, wants to know if it's more transmissible between people, does it also mean that you get sicker faster when you get it? Does it transmit faster inside?
Yeah.
I've not seen. I haven't seen any information again that it changes your clinical illness. If it's more transmissible between people, what does that mean? That means we need to continue to do the non-pharmaceutical interventions, and we know what those are: distancing, not gathering in groups, masking, hand washing, all of those things. It hasn't changed those properties at all.
Right.
So I think that's important for people to understand.
And what I've actually, there were some early reports that maybe the disease was less severe. I've not seen any further validation of that. I'm waiting for some stuff to get published by the CDC or World Health Organization or someone to start making. But it takes a while to study those questions. You'd want to know the answer right away, but we just don't know the answer right away. I think it's also important to point out to everybody that viral mutations occur all the time.
Yeah.
So this is not new, and what you don't read are all the mutations that may make this SARS-CoV-2 a little dumber instead of a little smarter.
Right. A lot of mutations we seem to think in viruses, 90% or more, actually are deleterious or cause the virus to not be able to replicate anymore.
So we'll take more of those.
We'll take more of those. But then there are the ones that have no changes whatsoever, make no difference whatsoever. And then you have some that may make it either more transmissible or cause lighter or heavier disease severity. Again, right now we think, well, maybe it's more transmissible, maybe because of some change in the conformation of the spike protein. But right now there doesn't look to be any difference in the clinical severity of the disease.
Okay, so this person says that my brother and his wife might be long haulers. They had mild COVID symptoms, but nearly 2 months later, they have COVID headaches, breathing, and heart issues, along with reduced kidney functionality. Is that all related to COVID?
Hard to know from just that description.
Yeah.
I mean, parts of it could be.
Yeah.
The long-term reduction in kidney function isn't really normally COVID per se, but maybe the effect of the treatment or how sick you got, but if they only had mild symptoms, it's kind of funny. I would advise someone like that to be sure you've been in touch with a primary care physician, and where needed, get in to see some specialty care and let them try and make an assessment. What you don't know is maybe again, we don't know the history. How much of that underlying disease was there, got unmasked, how much of it was COVID?
Absolutely.
I mean, there are clearly long-term cardiac effects and lung effects and brain effects from COVID in a small percentage of population, but are relatively small, but it is something that you have to contend with in the long run. And Hawkeye, we're not calling it a long haul clinic, but the COVID clinic that we're going to start here, that's about ready to go. I think.
It is. Yep. Just after the first of the year, we'll be ready to go. And again, it's kind of like a virtual clinic, but it's going to be a place where we have those systems in place to see. Again, a lot of this is going to, just as you said, going to be directed by your primary care provider. So probably do some cursory evaluation. Maybe that's labs, maybe that's a chest x-ray checking your O2 sat. And then from all of that data, then see who you need to see as a specialist. And that's what we'll be doing here as well. But it'll be ready access to pulmonary if you're having shortness of breath and cough still. Maybe it's to psychiatry, psychology, therapy if you're having that brain fog. Certainly cardiology if you need it. But a lot of that will go through the primary care provider to help direct those types of things.
Even what we know is that 15 to 20%, I think that's not that far off, of people will have a small decrement in lung function after COVID-19, meaning that, let's say they normally run at 90% of what they should be running, and all of a sudden they've dropped 5 or 10%. Many people will not feel that. They won't notice it unless they're a high-performance athlete. But on the other hand, if you've been a smoker and you had some long-term lung injury already, and then you get COVID-19 on top of that, and you drop from, say, I'm normally 60% of lung function, now I'm down to 40 or 45, whereas Hawkeye and I Hawkeye may be a more high-performance athlete than I am. No. We may not notice that so much, but someone otherwise will notice that. And so there's so much to that question that we just don't know the answer about. And the same thing can be true of your heart function. You know, if I ask Patrick Mahomes or the Chiefs or Tyrann Mathieu or someone like that, my gosh, if you drop 10% of your heart function, you're probably going to notice it because of the field of work you're in. But for most people, they may not notice it. So a lot of things to go on in that question, but there is a long-haul thing that we'll be starting the long-haul clinic. But in the long run, you're going to need to be evaluated by a pulmonary person and a heart person and a kidney person who've had, maybe a neurologist, who have had experience with some of these post-COVID effects and what the course of therapy would be. And that's what makes our clinic, for those who have had post-COVID illness, really attractive, because it's kind of a virtual, as you mentioned, it's a virtual clinic with telemedicine where you get consulting right up front, and then we can get you in to get more stuff done if we need to.
Yeah, absolutely. And we know that even people, like you said, young, healthy athletes, we know that Paul Pogba, who is a world-class midfielder for the French national team, he had mild disease, but he continued to have effects months after the initial infection too. So, you know, this affects everybody.
Yeah.
But you can seek help, and we can do what we can do to try and help you. But I think it will start with the primary care provider to really identify what are the most pressing needs and topics that need to be addressed by specialists if they do.
Patrick, have you all seen much of this? Have you, either in your staff or your patient population, are you seeing people come back after COVID saying, gosh, I just don't feel right, and it keeps going on?
Yeah, a little bit. I don't know that we have great data on it, but anecdotally, I've heard stories from providers about patients still struggling with it later, and we've had a few staff that have been out that have talked about still being tired, still having trouble breathing, even after a test is negative, and they're back at work and healthy enough to function and go to work, but still just sort of symptoms dragging on is definitely we're definitely seeing it.
Hey, those sneakers in your background there. Tell me what that picture means.
It is the first, I think, 30, maybe 25 pair of Air Jordan Nikes.
All right. Well, there you go.
Yeah,
I've just learned something.
It's a Father's Day gift collection from my wife, so
awesome.
It's on the wall.
Awesome, as it should be.
Kitty wants to know, how and when will younger people in the 20 to 40 age group who are uninsured be able to get vaccinated?
Patrick, what do you think?
20 to 30, is that what you said?
Yeah, 20 to 40. Yeah.
Oh man. I mean, you guys are the experts more than me, but it seems at this rate it's going to be, it's going to be March, April. But I've anecdotally, and please, you two experts, tell me where I'm wrong here. But one of my concerns is that given the number of people saying they're not going to get it, I actually think that people interested in getting it that are paying attention could have opportunity sooner, just because the quantity will be there, and there's such a prevalence of people not wanting it right away, that if people are watching, there might be opportunity.
I think that I think the response to this, the demographic response, is so unknown for all the reasons you just mentioned. First of all, vaccine production is starting to really ramp up, and Pfizer and Moderna have committed to another 100 million doses, which is altogether about 400 million doses between now and April 1st.
Yep.
That's a big number. That's 200 million people. So that means over half the U.S. population could get vaccinated, which is a good, obviously, really that's a good strong trend. And I'm with you. I don't know how many people are going to be. I mean, I think there'll be the vaccine hesitant group. I want to see how this goes. And I think here's my guess. The vaccine hesitant group are going to be able to do things the unvaccinated can't do, or if you don't have antibodies, and they're going to be healthier, and they're going to be able to get to go in and do do activities, so that there will be the sense from the people who haven't been vaccinated now they're going to want to go get into it. What I don't know is what that pivot point is going to be. And that's going to define, that pivot point around the population will define whether or not we get through people very rapidly or very slowly. And I don't have a way to predict that.
Yeah, no, I agree. And again, it's okay to be hesitant, continue to collect the appropriate data, the correct facts. But I think there will be other reasons because of hesitancy, and there will be reasons why people will get it. Maybe young people do have vulnerable populations in their family that they need to be able to go see their family. Maybe it's because they want to go to a concert or want to travel. And we see stories popping up now about certain private entities maybe mandating that somebody has a vaccine card or something to get into those things. And again, it's not government mandated. It would be by those private institutions or entities, so you can go and do things. And I think that's appropriate as well.
Vicki wants to know, can a virus just die out, and will COVID just die out?
Well, we want it to just die out. They don't just die out,
No.
but I don't mean to make that in a pejorative fashion or be negative about that at all. What I'm really thinking is, Hawk, as we know historically, some viruses come back, they alter their form, like influenza kind of comes back every year. Some viruses sort of fade from the scene.
Yeah. Well, we know SARS-CoV-1, the original SARS, faded from the scene because it was easy to trace those people. We knew you were not infectious until 5 to 7 days after infection, so we could stop that and put you and isolate you. That cannot happen here. It's very difficult because we know that you are probably most infectious 1 to 2 days prior to any symptoms to 1 to 2 days afterward. We know for MERS, another coronavirus disease, that still is going on. That has not faded away. So yeah, certainly a virus can just disappear. I don't believe that will happen here. We have other evidence of common endemic coronaviruses that cause common coughs and colds that it doesn't. But again, those diseases, those common coughs and colds, we don't know what happened when they first arrived into the human population, hundreds of years ago or 1,000 years ago. But certainly right now, there does not look like this entity will die out without man-made interventions, and whether that's the masking and distancing to the nth degree, and its vaccination and its therapeutics as well. But right now, there's no indication that it will just die out. Obviously, the temperatures don't have an effect on it, whether it's hot or cold in the area where you live does not have an effect. It will probably be here, but hopefully we can minimize it as much as possible.
I think that the one piece of good news from this, and please comment on this, that spike protein is pretty recognizable by our bodies. So you wonder if once you either get the vaccine or you've had it or you get exposed to it a couple of times, your body should have a pretty good host immunity and memory around that. And if SARS-CoV-2 loses the spike protein, it's really just another coronavirus. It's not SARS-CoV-2 anymore.
Yeah, and if it loses the protein or the binding domain, that's really the important part. That is the absolute tip of the spear of that spike protein that interacts with the receptor on our body. So if that changes to where it can't interact with the ACE2 receptor or some of the other lesser receptors in our body, then hopefully it will just die out. And what is going to happen as we get to 2 or 3 generations into this, and our young people who have grown up with this now are older? We don't know how that will happen through time. Obviously, we'll be watching that in the decades to come. But hopefully before that time, we will have even better vaccination, better therapeutics as well.
Isaac wants to know, might the vaccine rollout be playing a part in the falling caseloads?
We wondered about that. We'd like to say yes, but the truth is that the vaccine rollout is still in its infancy stage. So I don't think it'll be affecting the drop. We were at 12 or 1,300 new cases a day. We've gone down to 650 or 5. So part of that may be testing. But I think the real truth that we just have to recognize is it's way too early for vaccination to be having an impact like that on us. And so I don't think that's it. I think it's just more that, first of all, schools closed, right? Because after Thanksgiving, most schools didn't go back, which meant that I think schools were safe, but I think the difference is that the kids aren't congregating as much. I think people took more seriously. I think there was more masking, there was more distancing, and I think that really had an impact. And we've said all along, BKC, you can bend the curve. And I think that's exactly what happened. I think people bent the curve by following the pillars of infection control, which to this day and ongoing will always travel with you no matter where you go. Patrick, what did you all see in the community and in the dot? Did you think people started changing their behaviors right before Thanksgiving or after Thanksgiving?
That's a good question. I think after Thanksgiving, we've seen some significant change, particularly as another spike, and maybe the worst spike we've had this whole time, came around. I think the news coverage of hospitals filling and number of beds available and those kinds of numbers has been strong enough to influence behavior. I think it's also, to a part of the conversation before, has influenced people going to outpatient sort of regular checkups because people are hearing that hospitals are overwhelmed. So I think that definitely influenced people's behavior, and we saw some changes after the Thanksgiving holiday.
Did you observe more mask wearing in Wyandotte after Thanksgiving than before?
Man, that's a good question. I don't go out that much, so staying at home. So I don't know that I can speak to it, but I think we saw less pushback related to it when in our clinics to a degree. So I think anecdotally walking around and going to the store and that sort of thing, I think people seem to be sold on that as a solution, at least for a temporary time.
Well, it certainly worked. I mean, the data coming out of Kansas about the counties that masked against the counties that didn't mask is pretty striking. I mean, there's really no room for doubt here about how well masks work, Hawk.
Yeah, that, and I think that while there were probably some family get-togethers, I think there were a lot that did not happen this year, and I think that is one good thing as well. I don't know if there were still private get-togethers in homes with other friends, but maybe not those private get-togethers in home with that multi-generational, with the young babies up to the grandparents and great-grandparents. Hopefully that helped reduce the amount of spread as well.
Yeah, I think so.
Sharon and Amy and others are asking about different conditions in taking the vaccines, and their things that they're concerned about is if you're on blood thinners and if you're on immunosuppressive meds for arthritis.
Yeah, you bet. So I would say that if you're on a blood thinner, there is no reason to not take the vaccine. You can go do it just as you would the influenza vaccine or the MMR or any of the others you need to get. And as far as immunosuppressive drugs, because of some sort of condition like lupus or rheumatoid arthritis or things like that, again, all the more reason to get it because you're likely to have a bad outcome as a result, more likely to have a bad outcome because of SARS-CoV-2. So, Hawkeye, I don't think there are any medical contraindications about getting this vaccination.
Yeah, the one thing that I would be concerned about is if your immunosuppression is too high and the vaccine actually wouldn't cause an immune response. But if you're a provider that is providing and prescribing those medications really allows you and wants you to get influenza vaccine every year, you should probably go get this. They probably have a sense that this immune suppression that you're on, while decreasing your immune function, will still not decrease to the point where you won't make antibodies or have an immune response to this vaccine. So I would speak with your provider about that. But likely, if you're getting the tetanus vaccine every year, or if you've gotten a pneumonia vaccine recently, or influenza vaccine when you get it, on a yearly basis, you're probably still going to be okay to get this. The biggest concern is that the vaccine wouldn't take, but there is such a large spectrum of immunosuppression and what people are on. Some may affect you more than others, so just speak with your provider.
The other thing I would say, I follow a lot of patients who've had a lung transplant at Barnes, and they're getting all vaccinated too. Now, I've heard some transplant centers were a little more reluctant to jump right in, but I think most of them are getting vaccinated, so.
Rebecca is getting the vaccine today.
Yay, way to go, Rebecca. Good luck.
She's asking about if you have mast cell, should you pre-medicate with meds like Benadryl to help avoid allergic reaction?
Okay, if you have a mast cell histiocytosis or some even just mastocytosis,
What is
one of
that?
those other things. Yeah, we'll talk about that.
Okay.
Yeah,
Yep.
you know, I can't answer that specifically. I really don't have an idea. You know, Dr. Gear would certainly know. But again, I think it goes back to, are you able to get vaccines otherwise? Again, for the immunosuppressed population, based on the ACIP recommendations, you should be offered a vaccine. You can get these vaccines unless there is a contraindication for another reason that you can't get any vaccines.
So ACIP is who?
Is the
American Society of Infection Prevention, I think.
it's for the immunization practices.
Okay, so they're the people who really write the guidelines and help
Right, and they
all this. And
give their recommendations to the CDC.
And here's what, people with mast cell disease tend to react more than others. It's kind of a form of an allergy. So you think, oh, gee, I could be more allergic to it. And it's certainly going to take Benadryl or something of that nature will not prevent the vaccine from being effective.
Right.
And so if you're reassured, I think, go take a little bit of Benadryl, make sure you're up on all your other medications and take those. It's not going to hurt. Take your EpiPen with you because we always want to be ready because most people with mast cell disease tend to carry EpiPens or have allergic reactions. If not, get it done here. We're well equipped to handle an allergic reaction. No issues. But I wouldn't not get the vaccine. I would absolutely still go get the vaccine. And, I've got some health issues myself, and I know when the date comes for me to get a vaccine, I'm going to be ready to go. And I think you're coming up pretty soon, aren't you?
Tomorrow morning,
Awesome. Are we doing it here?
7 a.m.
Oh, we're not doing it here.
Can we have it done here to show people the process?
The only problem is the recovery period.
Well,
We would have to talk because we have, I don't know how many we're vaccinating today. I mean, we are getting a lot vaccinated this week. They have those practices up in our vaccination area, so we can certainly.
either way, we'll either get a video of it or we'll have you walk through the process.
7 a.m. And I know some of my colleagues got vaccinated Friday. Some are getting it today, so I'm in
You're
that
up.
second stage, that B group. Yeah.
Yeah, awesome. I think I'm somewhere in the C group, so I'll be hopefully sending them in the next couple of weeks. So that'd be
Yeah.
awesome. I'm looking forward to it.
So Kathy wants to know, she is a patient here, her primary care physician is here, her specialists are here. What is the protocol for getting the vaccine? Will we be alerted through MyChart?
Yeah, that's a great question. And I'll tell you what, to be honest, we are still working on that.
Yeah.
This is more than you want to know, but we are moving our vaccination program into Epic. Epic has a module for that. That goes live, I think, the 6th or 7th of January. And then, yes, I think that when we get ready to do that, we will over-communicate it with our patients about, here's your turn, here's when we can do it for you, here's how you schedule it. So you'll get a lot of information pushed out to you as soon as we get enough vaccine. We roll through a lot of people here to vaccinate our workforce, but we're hopeful that sometime by, I don't know, I don't want to put a date on it, but sometime in the not-so-distant future, we'll be able to start vaccinating patients. We're following, like Patrick said, we're trying to follow the rules of the CDC and making sure all the healthcare workforce is vaccinated. First responders, we're trying to make sure they're vaccinated, and essential workers, and then we're going to roll it out to the general public, and starting with those who are 74 and older. So I thought you want to add?
No, we have already have some of these practices in place in Epic, and that's with influenza vaccination and pneumovax or pneumonia vaccination as well. So this is probably going to be a degree or two above that to actively also seek out our outpatients and let them know. But that will be coming, and certainly I think that is one of the other benefits of an electronic medical record is to be able to set those types of things up.
Hawkeye, let's come in for just a minute, and then we'll have time for one more question about monoclonal antibodies, because that is also, I think, an effective therapy.
Yeah.
I had 2 folks get it last week, and I think
Yep.
they both benefited from it.
Yeah, absolutely. We have given, I don't know, maybe 60 by now doses. We do have a supply. We are working on expanding our supply to be able to get it more readily to those people that may be at high risk of hospitalization. We are working to get it into the emergency department. So if you come in for an evaluation and you're found to have COVID-19 and you're in that high-risk category, it can be done in the emergency department right there. But we are looking to expand access as much as we can because I think it does provide beneficial effects and reduce hospitalizations. That is certainly would be consistent with all the data at this point in time. So
Yeah, I think maybe toward the end of this week we can talk a little bit about that because there is, I think we've got some extra doses, and we want to make sure if you're over 65 or if you have chronic disease that you are being screened for having monoclonal antibody therapy. One more question.
Okay, so Mary and others have questions about testing. So I'm going to lump two test questions into one. The first part is, why would anybody who's asymptomatic go and get a test? Kansas is setting up more testing. How does that benefit or help? How do you know if you're asymptomatic to go and get a test? The second thing is the FDA-approved home testing and what you think about those.
Yeah, you bet. So, Patrick, you guys have done a lot of testing with Vibrant and continue to do that. Do you test many asymptomatic people?
We do. We test quite a few. Most of them have decided to get tested. Most people decide to get tested even if they are asymptomatic because they've been notified of a close contact, a recent close contact. So if someone they came into contact with tested positive, even if they don't have symptoms, they want to validate and should want to validate whether or not they are positive themselves. And so we through our drive-through pop-ups, we've tested quite a few asymptomatic people and encourage it, particularly if there's a known contact.
Yeah, I think that's a big deal, that known contact. But I would also just say that I think, if you're asymptomatic and you're getting tested, it's really a screening test. If you have no reason, you're just getting screened. And that helps us understand the disease prevalence in the community. That is, how many asymptomatic people may actually have the disease. And that's valuable information to us from an epidemiologic standpoint. So we like that. But on the other hand, I think we have to be thoughtful and recognize that most people who are asymptomatic, unless they're in some sort of screening protocol, aren't ever going to get tested, Hawk.
yeah, I think to Patrick's point, that's the best thing is we know that if you have had exposure, you should get tested. When to get tested, we really didn't know when those recommendations first came out to the CDC. But now with that ability to test out of quarantine, whether right or wrong, we know that you can seek testing even if you're asymptomatic if you were exposed. And so you're going to the first day you're going to be able to do that is 5 days after exposure, either the PCR or the antigen. In Kansas, it's a PCR test that's required. So really after that 5 day, probably more around that 7 day mark is really when you would like to get tested if you're otherwise asymptomatic. It's going to be hard as we aren't having masses of people who are asymptomatic going to get tested on a regular basis to identify true prevalence within the community. But certainly if you're asymptomatic and have had known exposure, it is recommended that you do go get tested.
All right. So the next question I think had to do with home testing. What do you think about those home testing kits?
I think it'll be good as long as you are doing it correctly, either watching a video that there's a link to or reading the instructions correctly, really getting that sample. Now, obviously, if it's a saliva test, it's going to be a little bit easier to get a sample. If it's anterior nares or just a nostril swab, that'll be a little bit easier than certainly getting a sample further back into the nasal passages. But I think those will be good. But the important thing to remember from that is, especially if you are symptomatic, or even if you've had exposure and are doing this as an asymptomatic, you need to either isolate if you're having symptoms or quarantine until you get those results back.
Yeah, I think that's right. And the other point, you have to pick the right one. And there's only one that you can, because now there's one that you can actually do at your home, and the results are given to you in your home, because the test gets more like a pregnancy test. It's all right there. And I just haven't seen the data around sensitivity and specificity, so I have a harder time commenting about it. But the FDA did approve that, so on an EUA, so early use authorization. So we'll see how that goes. Well, Patrick, thank you for being with us, and thanks for the great work that Vibrant does in our community. Final thoughts today.
No, I just appreciate you having me again and letting us share what Vibrant Health's doing and talk about this work in Wyandotte County. We got a lot of work ahead as the vaccine comes out, and a lot of communication, as one of the questions implied. So we just ask people to keep their eyes and ears out for info on vaccine and keep looking for their opportunity to get it.
Hawk, final thoughts?
Yeah, well, I just heard from our resident immunology expert, Dr. Gear, And she said she is recommending all of her mast cell patients do get the vaccine, but carry your EpiPen with you and probably monitor for 30 minutes afterwards. So I think that that's
Important information.
good information, yeah.
Ask
So-
her if she'll come on. And we'll talk
get
about it
Selena
more.
on.
We'll get her.
Yeah.
Yep. So tomorrow we have Dr. Barbara Pahood. She is the Research Director of Pediatric Infectious Disease at Children's Mercy and Clinical Associate Professor of Peds at the KU School of Medicine. She is also a vaccine expert, has helped develop vaccines of many different types. She's coming with Mario Castro, the Vice Chair for Clinical and Translational Research here at KU. He is practicing a pulmonary critical care doc as well, and we'll be delighted to have both of them back. They've been with us before. We're going to talk about a lot of different things around vaccinology, my fancy term for all things vaccine related. We'll also talk about a growing number of children who have had complications from COVID-19 and what our thoughts are around keeping schools safe. You know, the Christmas season is a pretty special deal. I had a great celebration with my family. Everybody was home, and we got to spend some time together. And I think Christmas is about many things, and one of the most important things is it's about hope. And hope is a powerful thing. And early on in this crisis, hope was what we had the most of. But over the course of the year, we've been able to combine some things with that. And one of those things has been science. And hope plus science, I think, is even more powerful when you try to put them together. You know, we've got remdesivir, we have anticoagulation, Decadron, and now we've had vaccines and monoclonal antibodies, and I think oral therapy for this, as things like Tamiflu kind of deal, might be on the way. We're pretty optimistic about that. So hope and science combined together still lacks one thing, and it lacks faith. You're the one that has to have the faith, because you're the hero. We've talked a lot about being a hero, and I think our city and our metro region have demonstrated the ability again to bend the curve. That makes everybody who's doing that a hero. Have the faith, have the hope, get the science, and together we can beat this disease. In the meantime, remember, there's still no place like home. We'll see you tomorrow.